Hello again, everyone. Okay, I will talk about post-therapy imaging. Imaging, as we heard many times during previous conferences, during today already, is one of the integral parts for theranostics. I will talk about post-therapy imaging mostly, what's the current state and where we ideally would like to be. These are my disclosures. And this is the overview, so I will touch a little bit on all these topics here, some of the gaps and barriers which we currently have, and some of the areas or directions where we think, or where I think, and many other colleagues actually as well, where we should go. This is not moving. So, currently drivers of theranostics, they're obviously clinical drivers, right? So this is why the field is advancing. We have the desire for more precision medicine. We have seen already improved outcomes with the current radiotheranostics indications which we have, and obviously, and this speaks mostly to the imaging, pre as well as post-therapy imaging, improved patient selection is very much hinging actually on the correct imaging. We have some economical drivers, and John McCann this morning spoke to that more sophisticatedly than I can from the industry perspective. And then we have system drivers. We have an aging population. I just had a round birthday, so I'm very much part of this. And we have increasing cancer incidences as well. In terms of imaging, PET-CT, I will start with PET-CT. Currently, what is internationally the standard is that there is no standard. So PET-CT is used for selection in pre-therapy imaging, but in post-therapy imaging, some do PET, some do SPECT, some don't have enough capacity on either camera. One thing I want to point out is that PET-CT here, specifically in Canada, is a little bit on the lower side. You see these comparisons, you probably have seen them many times before, that we do not have as many PET-CTs across the entire country. There are obviously geographical variances as many other OECD states. We do not have as good data actually for SPECT-CT because this inventory here doesn't differentiate between just purely gamma cameras and SPECT or SPECT-CT. So the number there is a little bit higher, but still kind of in the lower half of the OECD comparison. So some of the challenges which we have is, again, the scanner density on the PET-CT as well as on the SPECT-CT side, radiopharmaceutical supply and the geographical accessibility of it. Some of that was talked about just a minute ago. And staffing. The comment which was made previously that not only the remote areas, even the very centric areas here in Toronto have staffing issues as well. Not so much maybe on the physician side, but again, certainly on the MRT side. And again, we are also here in Toronto at UHN very much part of that. So if you know somebody, just let me know. Some of the major barriers, what everybody's talking about is that imaging is costly. It's not. Yes, it costs money, but in comparison to what the therapy costs and what we can actually avoid in costs with proper imaging-based selection, you see some of the pricing there, is actually only a fraction of it. And that has been published many, many times. Still, this notion persists that imaging, because we do it on a large scale, we do hundreds of scans every day, and so on and so forth, is very costly. It is on the bottom of the costs which we are all talking about here. That's why I've strategically placed it there. The drug costs and the therapy delivery or the therapy costs are much, much higher than the imaging. So this is much more doable than anything else. I'm coming to SPECT now because, again, I think SPECT is more the way to go for specifically post-therapy imaging than PET-CT. You see some of the examples here. Other direction. This one. You see that there are like the standard dual head cameras. You have full ring cameras as well. I'm not advocating for any of these, but these are the typical systems which you now have across the industry and in the institution, and specifically the whole body cameras have sped up the imaging acquisition quite a bit. So that's actually important for your capacity planning. This is one of the issues which we currently have, for example, that we have quite some patients, not enough capacity on cameras to image them all at all times. SPECT-CT is also now quantitative. Originally, SPECT-CT was considered as just a qualitative imaging modality. We compare between certain organs or certain areas within the body, but SPECT-CT is also quantitative. We can, as in PET-CT, measure the uptake. We can build ratios on a quantitative level within the community. This is not necessarily new news, but again, for the overall community and for the accessibility of the system, it is coming more and more into the clinics and into the hospitals, but it's certainly also not like broadly available yet. But again, SPECT-CT and SPECT can be quantitative. Systems are out there, and this is also what we are doing now. The reason for that is that the current nuclear medicine therapies have already a much more narrow therapeutic window than what we used to before from classical nuclear medicine, and future nuclear medicine therapies probably have an even more narrow window. In addition, I will not talk about dosimetry. There are others who can talk about that much better than I do, but you can do with the SPECT-CTs, you can do dosimetry as well. In theory, you can do it with PET, much more complicated, different research topic altogether. So dosimetry is also done on SPECT-CTs, and this is one of the additional reasons why this is probably a good way to go. Again, PET-CT has done advantage or has made some leaps as well. We are currently going from these like single body position systems to like whole or total body PET-CTs, very, very expensive. So that's why only very few institutions have those. We are currently in the process of buying one. It is the single most expensive piece of equipment I was ever part of in RFP. And these are great systems. They will increase your capacity, your research capacity, and access to PET imaging overall. But again, not everybody has the infrastructure and maybe, at least not currently, the resources to buy one of those. Coming back to the economic factor for SPECT-CT, there's a couple of papers. One of the best ones, I think, is this one here, where they, for prostate cancer, showed that post-therapy SPECT-CT actually altered the management in 50% of patients. From our perspective, that seems a little high, but this is what is quoted here. 28% progression detected, so therapy was stopped. This can be probably partly not only be attributed to the SPECT-CT, but you have clinical parameters, blood parameters, and so on as well. But there's an additional information. What's probably more interesting is that the 20% of showed very favorable response, and that you can either pause or delay therapy. So that stretches actually the therapy cycles which you have, and give the patient a break, and actually not necessarily improve the outcome, but prolongs actually the time which patients can be under therapy, which are, again, fairly costly as well. So potentially very cost-effective monitoring tool, because, again, it can be obtained after every cycle. It is not free, but you don't have you still have to have the system and the staffing for it, but you don't need the additional injection of a radiopharmaceutical because you image the therapy injection directly itself. This is an overview from the PSMA, USLA, UCSF PSMA conference this spring, where they also alluded actually to exactly the same thing. There's no additional tracer injection, so no additional costs associated with it. You can do imaging after every cycle. If you want to do that with a PET-CT, it's probably a little bit costly for your institution, depending on what the reimbursement is, obviously. The management information from SPECT-CT, quantitative SPECT-CT and PET-CT is probably comparable. That's what the community so far has settled on. You don't have an issue with baseline timing because, again, you can do it after every cycle. The injection from the therapy is in there already. You have a direct biological response assessment available, and you can adapt a therapy, at least stopping or pausing in the current setting. With that, in summary, improved SPECT-CT, so coming back to the original topic where we think this, across these barriers, the post-therapy imaging should go. We think that this is should be SPECT-CT. With the current technology, it's very well possible. It enables personalized therapy follow-up. It enables dosimetry. Again, different topic, which I'm not going to touch on, but it's in there as well for this increase in patient population which we have. Potentially cost-effective because, again, some of the costs associated with other imaging modalities you do not have anymore with this. PET-CT certainly still has a role. So if we have examples where you have very, very small lesions by the end of the therapy and you want higher resolution imaging, for example, to evaluate any local additional therapies after the end of the radiotheranostics cycles, that's an option as well. So PET-CT has certainly a role in there, but not maybe a continuous one after each cycle. And then, this is the end of that talk. I just want to do 2 slides for the Oncidium Foundation. I think they don't have the opportunity to be here. I'm an ambassador of this foundation. Many others here in the room are actually as well. Just want to focus your attention on the foundation. It is for non-profit and a public benefit organization which is advocating for access for radioligand therapy or radiotheranostics. Does several teaching initiatives and awareness initiatives for fair access and fair distribution of radioligand therapy. And with that, I would like to thank you for your attention.